Welcome back. We're going to wrap things up with a discussion on inodilators. This includes dobutamine and Milrinone mainly. Since isoproterenol technically falls in this category, we'll also do a brief talk on it as well. Ino meaning contractility, in this case increasing contractility, and dilator signifying a reduction in SVR and sometimes PVR. Through the combination of increased cardiac contractility and reduction of afterload, the goal of these medications are to improve forward flow, i.e. increase cardiac output. It should be also understood that these medications can increase heart rate. First up is dobutamine. Now, dobutamine is a synthetic catecholamine and it's derived from dopamine. The medication agonizes beta-1 and beta-2 receptors, and as we should know by now, beta-1 stimulation induces inotropy and chronotropy, and beta-2 stimulation induces vasodilatation. So overall, dobutamine's inotropic effects are stronger than its vasodilatory effects by about a ratio of 3-to-1. And why? Well, technically there's also alpha-1 agonism, but the net effect when combined with the beta-2 is just mild vasodilatation when dobutamine is used at low to moderate dosing. We do need to pay attention to this alpha-1 stimulation if the patient's on high dose dobutamine, and at higher doses the alpha-1 can overcome the beta-2 agonism, and that in itself should question the use of high dose dobutamine. The overall mechanical effects of the drug include an increase in cardiac output and a decrease in SVR and left ventricular end diastolic pressure. Now, unfortunately, the drug increases myocardial oxygen consumption, it's pro-arrhythmic, and in certain populations it can cause actual hypotension. Dosing's 2 to 20 mics per kilo per minute. Now, a bit more with dosing, and some folks might not agree with me, and that's okay, as long as I got you to think about it. I have a soft max of 10 mics per kilo per minute, at least in my head, and I say this for the following 5 reasons. 1. We know that higher doses of dobutamine invoke stronger alpha-1 agonism, potentially eliminating the vasodilatory effect that we initially sought out. 2. Old animal models show concerning effects with high doses of dobutamine, albeit with long-term therapy. 3. There's a clear signal in data showing escalating inotropes and cardiogenic shock results in increased mortality. 4. Literature tells us that there's more tachycardia and arrhythmias associated with these higher doses. Lastly, the National Cardiogenic Shock Initiative is showing us a better way of managing acute MI and cardiogenic shock. This includes using mechanical support and early offloading, culprit vessel revascularization, PA catheter-directed monitoring and intervention, and aggressive attempts to reduce these catecholamines. A quick comment on the duration of action, and this discussion will evolve here in just a few minutes, but dobutamine's duration of action is about 10 minutes, which is a clear benefit of the medication. Now let's move on to Milrinone. This synthetic medication is a phosphodiesterase inhibitor, type 3. It's not a catecholamine. It has a positive inotropic, positive chronotropic, and positive leukotropic effect, and it's also a very powerful vasodilator. Now, this medication wears a bunch of hats, and depending on your specialty, you might see it used in various ways. In cardiac surgery, it's associated with improved first attempt to come off pump. It also increases IMA and saphenous vein graft flow, but it also, like everything else in cardiac surgery, increases post-op AFib. In the neurocritical care unit, you might use it to reverse cerebral vasospasm and subarachnoid hemorrhage. But today we're discussing its use in cardiogenic shock and possibly in RV failure pulmonary hypertension. Like I said, this isn't a catecholamine like dobutamine. Phosphodiesterase inhibitors lead to increased intercellular concentrations of cyclic AMP, and this leads to increased myocardial contraction and relaxation of the vascular smooth muscle, all while not stimulating the beta receptor. Dosing's between 0.25 and 0.75 mics per kilo per minute, and while some references still tell you to bolus this medication, I wouldn't recommend this outside the cardiovascular OR setting. The drug has a decent onset of action, but the big thing that I want to highlight here is the duration of action. It acts up to 3 to 5 hours, and since it's renally eliminated, if your patient has kidney injury or insufficiency, this will increase the duration of action even longer. So knowing this information is vital in understanding when you wean this medication, but overall it might be vital in understanding it when you're selecting this drug for your patient. As you can imagine, Milrinone increases cardiac output, and it decreases arterial blood pressure, left ventricular end diastolic pressure, PVR, and SVR. This makes it a great medication for some variants of shock, halting that infamous downward death spiral of cardiogenic shock that you see here on the slide. Now let's take a look at some pros and cons of this medication. So the obvious pros of this medication is it has similar inotropic activity as dobutamine. It has no alpha agonism. It's more potent of a vasodilatory medication when compared to dobutamine. In addition, it has little effect on myocardial oxygen consumption. Said a little differently, maybe more conservatively, it has less negative effect on myocardial oxygen consumption than dobutamine does. And then lastly, there's less tachycardia with the use of Milrinone in comparison to dobutamine. So what are the cons? And to me, they are kind of big cons here. So hypotension is more common. This is a more powerful vasodilatory medication, and the long duration of action is a tough one to bite off sometimes, especially if the patient is suffering from renal insufficiency. So during talks like this, I get the same question all the time. What medication do I pick for my patient? And really, that's a tough one to answer. I try to take a look at a few questions when I answer questions like this. So first of all, what's the patient's disease process? Does the patient have pulmonary hypertension, RV failure, LV failure, biventricular failure? It really matters when we take a look at this. Next, is the patient hypotensive? So both of these medications are going to vasodilate, but Milrinone is going to do more so. And if the patient is hypotensive, how much inopressor are they on? There's a difference between a patient on a whiff of norepinephrine compared to a patient on 0.6 mics per kilo per minute of norepinephrine that we're considering putting on a vasodilatory medication, an inodilator medication. So that brings us to an even further question: is starting an inodilator therapy safe right now? And if you're sitting on the fence, if you're on the borderline, maybe you should use dobutamine instead of Milrinone, because if you make the wrong call, you're only rescuing the patient. You're only supporting the patient for about 10 minutes, 20 minutes tops. Next, is the patient hypovolemic? And if so, let's get that patient urovolemic before starting inodilator therapy, at least in the shock patient. Starting these medications in hypovolemic conditions will result in more tachycardia and more proarrhythmic events. Next, does the patient have severe renal dysfunction? And this one really worries me because we're already dealing with a duration of action about 3 to 5 hours. So I always say 4 hours in my head. Now add renal dysfunction to this, and you might be dealing with a duration of action of 6 to 8, maybe even 12 hours. So if you make the wrong call in introducing one of these medications, you're going to be rescuing, you're going to be supporting that patient much longer than you did on dobutamine. And then lastly, was or is the patient on the beta blocker? So if we slow down and think about this for a second, a beta blocker is a beta antagonist. Dobutamine would be a beta agonist. So essentially, they're going to render each other ineffective. So we may want to take advantage of the alternative mechanism of action that Milrinone possesses to have a more effective treatment regimen. Last up is isoproterenol. Among other uses, it's used for unstable bradycardia. With that said, it's weird that I even mentioned this during this lecture, but technically it is an inodilator. Now, if and when we use this medication in the ICU, it's for bradycardia. We don't use it for its inodilator properties. Isoproterenol is a potent synthetic beta-1 and beta-2 agonist, and there may be very low affinity for alpha-1 agonism. Truthfully, it's debatable if alpha stimulation even exists. If it does, it doesn't seem to be clinically significant. Isoproterenol has positive chronotropic, dromotropic, inotropic, and vasodilatory properties. The general hemodynamic changes when you implement this medication is obviously an increase in heart rate. We do see a decrease in diastolic blood pressure due to the vasodilatory effect, and generally we see an increase in systolic pressure due to the increase in stroke volume due to the increase in contractility. Unfortunately, this medication significantly increases myocardial oxygen consumption without compensating in coronary blood flow. So definitely avoid this medication in the setting of cardiac ischemia or risk thereof. Overall, this medication is effective at increasing the heart rate. There are some overwhelming concerns though too, including cardiac ischemia, hypertension, sometimes even hypotension, and lastly, costs. This medication can be administered peripherally given its lack of vasoconstrictive effect. As far as dosing, at least in the ICU, it ranges from 0.5 to 10 mics per minute, and I would really use caution at doses 5 mics a minute or greater. Isoproterenol is used a lot in the EP lab, and maybe this is why EP physicians are more comfortable using this medication in the ICU. As far as electrophysiology, it has multiple purposes in the lab. It can provoke SVT, certain types of VT, and it can identify AFib ablation triggers. It's even been used historically to provoke syncope during some tilt table testing. But quite honestly, where does it fit into the bedside care in the ICU in 2023? Well, technically, it still carries a 2B recommendation for use in symptomatic bradycardia. As you can see here, in the setting of low likelihood of coronary ischemia, isoproterenol, dopamine, dobutamine, and epinephrine may be considered to increase heart rate and improve symptoms. I'll point out 2 quick thoughts here. 1, a grade 2B recommendation is a weak recommendation. It also states that alternative approaches may be better for some patients under some circumstances. And then 2, this recommendation also includes dopamine and epinephrine as an alternative, which is a fraction of the cost of isoproterenol. Speaking of cost, isoproterenol prices increased by a factor of almost 70 in 2015. It went from $26 per milligram to almost $1,800 per milligram. And initially, this wasn't even provoked by a drug shortage. In 2015, Company X bought Company Y. Then Company Y turned around and increased the cost to $218 per milligram. And then in the same year, Company Z bought the company from Company Y, and then Company Z turned around and increased the cost to $1,200 per milligram. Now, who knows what happened through the COVID era, but my organization's current acquisition cost is $529 per milligram. So you figure running it at conservative doses of 2 mics per minute, this would equate to about 24 hours of therapy costing in excess of $1,000. In addition, there seems to be a paucity in literature as far as epi versus isoproterenol or dopamine versus isoproterenol. Are they equally effective? Is there increased risk for harm with isoproterenol? We don't know. And obviously, I've already laid out the cost issue. So in closing, this drug isn't even used as an inodilator. It still fits within that drug class. It's used as an agent to treat unstable bradycardia. There's a handful of cheaper alternatives that will work in the majority of patients. Maybe it has a role in patients that are refractory to dopamine and epi. However, at this point, I'm putting in a transvenous pacer. Now, if you're at a facility that doesn't have that capability, or maybe you don't have that skill set yet, maybe this drug can function as an alternative for a rescue therapy in bradycardia. Just be mindful of how expensive this medication is. So that wraps up our discussion on inodilators. Next up is a nice discussion regarding vasoactive agents and peripheral IVs.